Good morning, everyone, and welcome to our NCAS Journal Club this morning. As you know, we are recording this and you can catch up if you have missed it on our NCAS website. And thank you to Arjun for getting up very early in Western Australia to get it going. As we gather for this meeting, physically dispersed and virtually constructed, let's take a moment to the meaning of place, and doing so recognise the various traditional lands on which we do our business today. We acknowledge the elders past, present and emerging of all the land we work and live on, and their ancestral spirits with gratitude and respect. So this morning, I am truly excited to have Esmita, who is a wonderful friend and colleague of mine, and who I've been following for many years because I truly believe that she's been leading the evidence around the role of behavioural science in antimicrobial stewardship. She is a research lead for practice design and engineering in Imperial College London. She's an honorary associate professor at the University of Cape Town. And in fact, we bonded over a safari in Cougar National Park a couple of years ago. And she's a postdoctoral leader leading all sorts of incredible things, and particularly in Africa and in South Africa. And I'm sure you're going to find her presentation this morning fascinating and inspiring. And my introduction doesn't do justice as Esmita, but I think it will speak for itself once you start talking about what you do. So welcome and thank you so much for joining us this morning.
Good morning, everyone in Australia. It's such a pleasure to be joining you via Zoom. And thank you so much for that introduction, Kaz. It's so lovely to see you. I had to join live. I was telling Kaz just to speak to her and see her. We haven't seen each other for 2 years. So I'm going to talk today about the work that we have been doing in the UK and in some other countries around better understanding the role that behavior has in antibiotic prescribing decision-making in hospital settings, where most of our research is focused, and why we think culture matters in antibiotic prescribing. So without further ado, I'm going to start talking and you can ask me questions at the end. But basically, I'm going to be discussing some of the work that we have done around understanding culture and team dynamics and infection-related behaviors in the UK, in the hospitals that we have been working in the UK, and how we've translated that research to other settings to understand the universal cultures across healthcare tribes or hierarchies or systems, if you like, that are affecting behaviors around antibiotic use. And this is despite the evidence base that we have about what should be or what works in terms of antibiotic stewardship interventions and infection prevention and control behaviors. And the more that I have been working with colleagues around the world, the more I've come to realize that we also need to look at how we have to strive continuously to do this research in a more equitable and inclusive way. And that's something that I'm also going to be talking a little bit about, particularly around involving different healthcare professionals from different disciplines, but also across countries, how we can work much more equitably together to be able to address the threat of antibiotic resistance, which we are all faced with. I'm aware I'm speaking to a very knowledgeable audience, so I'm not going to keep talking about antibiotic resistance itself, but I think it's important to highlight that regardless of the many different drivers for antibiotic resistance, overuse of antibiotics in human and animal populations remain two of the most important drivers for antibiotic resistance. And in fact, it's not just overuse, it's any use of antibiotics, whether it's over, under, misuse, or even appropriate use, as we know, can lead to antibiotic resistance. So our efforts aren't about minimizing antibiotic use, but optimizing it for those patients who need them. And we shouldn't forget that more people die still from lack of access to antibiotics and effective therapies than from antibiotic resistance. So it's about ensuring equitable access to antibiotics to those who need it and optimizing their use. And of course, this is something that we have seen, that the rapid spread of infectious diseases in the last 2 years with the COVID pandemic, but it's the same with antibiotic resistance. As soon as the pathogen is comes to the surface or comes to the fore as a potential pathogen in hospitals or in human populations in any part of the world, very rapidly spreads around the world. So bacteria don't recognize cultural or geographical boundaries, and we need to also increasingly work together across different collaborations and across the globe to be able to address the threat of antibiotic resistance. And that's something that we are trying to foster by building more international partnerships to better understand this threat from different perspectives and across different resource settings. And when we last looked at the existing interventions that have been published around optimizing antibiotic use in hospital settings, one of the key things that we observed was that very few of the interventions actually consider the theoretical rationale for choosing specific interventions. And we all know what it is like working in healthcare. We often have to work to time pressures. We have very little time to do research, to be able to implement evidence-based practice. Or often we take evidence from another setting and expect it to work in the same way in our own setting. And of course, we know that doesn't always work because of decline effect, because of different cultures and contexts influencing outcomes of interventions. And the Cochrane Systematic Review, one of the key findings was that the majority of interventions that were reporting success focused on restrictive modes of methodologies and approaches. And these, of course, we know work in the short term, but restrictive interventions in the long term aren't effective in sustainably changing behaviors. So that's something that we took upon ourselves to do more research, to apply social science methods to understand how and why people behave the way they do around antibiotic use in hospital settings. And the reason why this is important is that, as I mentioned, we all work across different healthcare, we all work with different healthcare resources. And I learned this also working with Professor Thursky and other colleagues in Australia when we were writing a grant around access to antibiotic use in surgical teams, how different medication systems are used in Australia. So regardless of where we are in the world, we are working with different resource limitations. And these are just some of the examples of current innovation in antibiotic prescribing around the world. The first photograph is from a hospital in Uganda where paper is very expensive in Uganda. So having paper charts, we tried to do a pilot project to roll out paper prescriptions in a hospital there, and it's a very costly intervention. So often hospitals do not have the resources to have prescription charts, and doctors have to make do with makeshift prescription charts in exercise books. And of course, this has implications for patient safety, for medication safety, but also for appropriate antibiotic use and prescribing. But that in that setting is an innovation. And the same, this is from our hospital in Kerala, where we have collaborations, which I'll talk a little bit about later. The team identified one of the key problems with antibiotics was missed doses, because the paper records are all loose and the prescription chart kept getting missed. So they created a very simple innovation of having a highlighted border on the antibiotic chart so that the nurses could find them much more quickly in the medication notes for the patients. And it meant that it reduced delayed antibiotic prescribing for the patients who were prescribed intravenous antibiotics. And the third example is innovation in the University of Cape Town, where our colleagues have invented a very instructive prescription chart, which is a paper chart, but they have brought in all the elements of antibiotic stewardship to guide physicians in prescribing antibiotics appropriately. And they've published the success of this in improving the quality of prescribing for the patient cohorts. The last example is what we use at our hospital at Imperial in London, which is the electronic prescription chart. We use Cerner at Imperial, and it was a system that we had to buy off the shelf. So we didn't have much choice in the setup of this electronic prescribing system. And the ethnography work that I did in the hospital, looking at behaviors of medics and surgeons in relation to antibiotic prescribing, just happened to be at a time when we were transitioning from paper records to this Cerner system. And it was fascinating as a sort of a by the way outcome of the research that I was doing, to observe how people's behaviors change depending on whether they were using paper records or medication, electronic medication systems, and how when we had paper charts, the patient was central to the ward round, and everybody would go and bring the different pieces of information to discuss around the patient bedside, including the prescription chart. As soon as we moved to Cerner, everybody congregated around these computer on wheels, we call them, and the patient almost became a satellite, and everybody was worried about the radiography and everybody, another observation was that people would only ever read their own notes, whereas in paper medication records, you'd have to go through and your eye would come across other people's notes, at least, even if you didn't want to, but it can become much more selective in electronic prescribing systems. So for all of these reasons, it's really important for us to understand when we implement antibiotic prescribing interventions, or when we build expectations around what an antibiotic stewardship intervention should be, is first understand the context that we are working in and the existing resources that we have to work with. And I think these are, regardless of all of these examples, there are limitations to all of them when it comes to optimizing antibiotic use. And I really like this example of design in healthcare, because we've been involved for several years in designing better clinical decision support systems. This is the slides that one of our professors in design at the Dyson School of Technology at Imperial uses to describe the design process. And we don't do this enough in healthcare. We are always stuck in if we are lucky and we have funding, we're stuck in the research phase of trying to develop interventions. We do not have the luxury to spend time to conceptualize the work that we want to do, to be able to develop better or design better systems to work with. And this is just as the example is as applicable to prescribing systems as it is to developing better diagnostics for antibiotic stewardship. We're always working in a much more restricted time and funding space to develop interventions for stewardship. So we don't have the luxury to think through the interventions that we want to develop to make sure that they work in the context. And as I said, this is the same example that can be applied to diagnostics. So these are examples of current systems in use around the world to aid prescribing, antibiotic prescribing and infection management. The first photograph, these two are from Shisha Hospital in Dhaka, which is a sort of a leading pediatric hospital in the country in Bangladesh. And the egg incubator that was used to eradicate smallpox still works alongside high-tech equipment, supporting the fantastic team at that hospital who do incredible research in childhood bacterial infectious diseases. And their ANISA trial was published in Lancet, and I urge anyone to read it because it's a fantastic example of how research around infection management and antibiotic use can be galvanized in any setting using local resources. So this particular team, they use community healthcare workers, predominantly female community healthcare workers, to do most of their surveillance for them. But they have fantastic research to support the implementation of interventions in Bangladesh around pediatric infectious diseases. But in terms of coming back to laboratory capacity, and then these two are working laboratories at the University of Khartoum in Sudan. So we're working in very different contexts. So when we talk about rapid diagnostics to support antibiotic use, when we talk about technology, we have to understand how they will fit different contexts. I use these examples, but we have also done work with Norway, with University of Bergen, where we investigated access to the microbiological laboratory to support antibiotic stewardship. And when I went to do this research with our colleagues in Norway, I didn't anticipate there to be any resource limitations in that particular country because of the healthcare system there and the availability of resources. But because the Norwegian population is geographically spread across a very large area, and not all the hospitals have access to medical microbiology laboratories. So there's a lot of antibiotic decision making in Norway that is being made in different hospitals that is without access to diagnostics. So again, it comes back to looking at the resources that we have in the setting that we're working when we develop interventions. And alongside that, also really critical is to understand all the different people, all the actors that are involved in delivery of healthcare, and who are going to use the interventions or who are going to interact with the infection prevention and control and antibiotic stewardship interventions that we're going to implement in hospital settings. There are nurses, doctors, radiographers, pharmacists, and alongside them we have all the researchers, including some of you and myself who may have dual roles, both clinical and research, but it's a huge arena in which we are trying to bring about change and influence behaviors. And the end role for all of these is around patients and carers, is we want the best outcome for patients and carers. And one of the things that I've learned in the research that we have undertaken is that whilst all of these individuals and actors may mean very well for the patient and want the best outcome, we all have different expectations of what is the best outcome, and we all have different risks that we use to navigate our behaviors. So this applies to the risk of antibiotic resistance against all the other risks as patient outcomes which we consider. So as an antibiotic stewardship representative, I don't always talk about antibiotic resistance when I'm talking to people. I try to understand what risks it is that they associate with as important outcomes for their patients, and then we can come to a common ground on how we can change and influence behaviors. I don't know if you can see, because I have the videos on the side, but on the side of my slide, I also have the role of ethicists, I think, including an understanding of the ethical dilemmas that we have in research is becoming more critical, particularly when we also do research across different healthcare organizations and different healthcare settings and resources, to ensure that we're always abiding by research that is ethical but also is equitable, that we're including everybody who needs to be included. And I'll talk a little bit about this in the context of patients and carers later. So when we began our research journey at Imperial, we were funded on the back of the Cochrane systematic review that we had done, and we had identified this gap in contextual knowledge around antibiotic stewardship interventions. We were funded to do research that leaned more towards the social sciences aspect, and I had to learn this. I'm not a social scientist by training, I'm a pharmacist, so I had to learn how to conduct more qualitative research to understand how we can improve the interventions that we have around antibiotic stewardship. And we focused first at Imperial in London, where we were working, and we looked at the literature, and as I described, we identified the gap in literature. This is 10 years ago. Things have changed a lot in the last 10 years, including some fantastic work from the team I'm presenting to today, Professor Thursky's team and others in Australia and around the world, who have contributed to the social science research out there around better understanding the drivers for antibiotic use. But when we started our research, we interviewed our healthcare professionals across our hospitals, including nurses, pharmacists, and doctors, and tried to understand what drove their behaviors, what determined their antibiotic prescribing behaviors. And we did this using a theory of culture that was first developed by Spradley, which is about the behaviors that people learn as groups or as members of groups, and how that shapes the behaving and decision-making of individuals. And what we described was that despite the existence of policy and guidelines, which clearly indicate what needs to be done for patient outcomes, healthcare professionals work in very hierarchical teams, and these hierarchies determine the behaviors of individuals, particularly around antibiotic use. It's this reluctance to want to question the prescribing of colleagues, even if you consider it to be inappropriate, the need for clinical autonomy that physicians express, that regardless of their specialty, because of the ubiquitous nature of infections, people feel that they have the expertise to manage and treat the infections that they encounter in their patient population. And this is something that is always a sort of a power dilemma between infectious diseases and medical microbiologists and other specialties, which we need to understand and tackle. So we described these unwritten rules, which was then picked up by colleagues around the world. And one of the nicest things for me in this research was whoever I spoke to said to me, "You're describing my hospital. This is exactly what's happening in our setting." And that was very interesting to me, because it spoke to a culture that is universal within healthcare in terms of how we train, how we implement healthcare, and how we work together. There is an identity we have that is across different nationalities, and that was very interesting for me and something we wanted to pursue and look into further. And we did this we looked at, for my PhD, I replicated the study in France, in Burkina Faso, India, Norway, and the UK. And again, it was the same themes that were emerging from this research around what drives antibiotic prescribing in hospital settings. And one of the key themes that was coming through was everybody was telling me that the surgical teams are much more difficult to engage with. And this was something that we were interested to look into more in more detail, because one of the first divisions and specialism in hospital settings, of course, is medicine and surgery. And although there are many different subspecialties within this which have their own culture or their own sort of social norms in terms of working and behaviors, we had identified that when we look at antibiotic stewardship interventions, the majority of them tended to be in medical specialties, and the surgical specialty was overlooked. And when we spoke to our clinicians and our colleagues, the reasons they would give is that, well, nothing much happens in surgery, people just get surgical prophylaxis, or that surgeons are very difficult to engage with on a stewardship, and we would rather work on the low-hanging fruit. So we conducted an ethnographic study which meant spending a lot of time observing practices across medical and surgical teams and seeing how they work together as members of a team, how they interact with ID and stewardship teams, and how they use the clinical tools within their sort of clinical environment to make decision-making in relation to infection management. And we mapped the surgical pathway in terms of all the drivers, all the points within the surgical pathway that have an influence on outcomes. And when we look at the literature, the majority of the evidence for stewardship tends to focus on preventing surgical infection through prophylaxis and management of surgical site infection. There was a gap in what happens to patients who are looked after by surgical specialties and what happens to patients post-operatively. And we also collected qualitative data from medicine and surgery. This was acute medicine and acute surgical teams. And we described that, quantitative data. And with the quantitative data, we were able to describe actually there is a big difference between these two teams or specialties. And what tends to happen is in medical teams, patients come in through A&E often for acute medical care. And whilst in A&E, there may be some inappropriate prescribing or some broad spectrum antibiotic prescribing, it is narrowed down once they are triaged into the specialties and the care of the patient is streamlined against existing protocols. And we also observed greater pharmacist engagement in stewardship activities in medical teams. In surgery, what tends to happen is that patients are over-prescribed surgical prophylaxis, more than one dose, or post-operatively, a lot of patients end up on inappropriate intravenous inappropriate antibiotics for a prolonged period of time. And surgical patients are going home with courses of antibiotics. I think we reported 50% of our patients were going home with antibiotics post-operatively. So there was a big gap in how we can optimize antibiotic use in the surgical pathway. And at the time that we did our study, there was also fantastic research coming out of South Africa and colleagues across Africa, the ASOS study, which was looking at surgical outcomes. It's the African Surgical Outcomes Study. And they also described that infection is one of the unintended consequences of surgical intervention in African settings. So this is something that we wanted to pursue. And it was very fortunate for us at the time. We had a big grant to do it. And I'll go into that in a second. But what also happened for us in the UK is when we published our research, 2 of the surgical trainees in our hospital took this up and developed a study to see how they can better engage with the surgical teams on antibiotic use within the ward round setting. Because one of the things we identified is the surgical ward round is so busy and there are so many things that need to be discussed that antibiotic decision-making often tends to fall off the discussions and is something that is left to the junior doctors to pick up afterwards. And that's where a lot of delayed stopping of antibiotics occurs. A lot of patients end up on antibiotics unnecessarily for a long period of time, not because they need it, but because nobody has reviewed it. And the junior team don't want to make changes until the senior consultants get involved. So it was very nice for us that we saw 2 surgical trainees pick this up and they were able to develop a sort of a checklist for the ward round that they demonstrated improved antibiotic use once this checklist was used continuously on the wards, on the surgical wards. But back to our research. So when we did this qualitative work and we published it, it was very fortunate at the time the Economic and Social Research Council had put a call for greater use of social science research to build collaborations internationally around antibiotic use. And we used the data that we had from our work in the UK, and we worked with colleagues in South Africa and India to develop a study specifically trying to understand how we can co-design context-relevant interventions for surgical specialties in low and middle-income countries to address antibiotic prescribing. And this meant spending a lot of time going to both different countries, both South Africa and India, to understand the contextual drivers in those settings and training our colleagues, early career researchers that we had in the study in those settings, to be able to implement these studies themselves. And again, for me, I was very fortunate. I was the person who went out to train our colleagues in those countries, because I had an insight into how much context influences decision-making in different settings, and how much we need to understand about the cultural and social norms in different settings when we look at developing our expectations around antibiotic stewardship and infection management. So this is a photograph of outside of the ICU of the hospital in Kerala where we work. And one of the infection prevention and control measures is that everybody has to take one's shoes off before going into the ICU. Of course, they wear overshoes, or some people going, the relatives and carers sometimes going barefoot. But for me, this was also an indication of the traffic through this unmanned ICU at any given time, and how many people were going through, and what sources of infection that was posing in terms of risk for the patients. And I come from Iran, so for us, taking your shoe off to go into somebody's house is what you do. And so, you know, it's culturally, it's a sign of respect, but also it is a sign of infection prevention in that particular hospital, that you have to take off your shoes when you go into a highly sterile or clean environment. So these are the things, these are the reasons why context is so important when we develop infection prevention and control practices. And it would have been bizarre or completely inappropriate if we had just taken the IPC rules or settings that we had in South Africa or in India or in the UK and taken them to India, or vice versa. So we should always understand this when we develop interventions. And international guidelines and policies don't understand this enough, don't take this into account enough. And I'll talk about that a little bit later, particularly around patients and carers. One of the things that we did very early on in this study, we were very mindful that we're working in a collaboration that is international, that we have early career researchers and people with different levels of experience in conducting the kind of research we wanted to conduct. So we looked to implementing capacity building as a central part of our research, and we followed the WHO Essence criteria for capacity building. So this is our example on the my right is the our study, the Aspire study, which followed the Essence criteria. And this is the stewardship program in India, in the hospital where we are, which we also felt had also followed the Essence criteria. And this was about building partnerships that are successful, that are built on strong collaborations. And from the very beginning, we made sure that the research program was co-designed with local partners, and we had patient representatives and inclusion of surgical partners in the research that we were doing. We had effective leadership through the leadership of Professor Sanjeev Singh in India. We had Professor Mark Mendelsohn in South Africa and Professor Alison Holmes in the UK. And these were PIs who had a track record of working together, so there was respect and trust from the beginning in this project. We worked very closely with the stakeholders, including nursing, anesthesiology, microbiology, and pharmacy. And the contextual insight was really important. This was about spending time in each setting, training our early career researchers to conduct the research to the same quality in the different countries, and also for gaining access to the teams. It was essential that we had the leadership that we did to enable us to have access to these teams and spending this time building this capacity really served us well, because we didn't know that COVID-19 was going to happen. But having invested in this, we were able to, and we have been able to carry on with our research throughout the pandemic without any of us being able to travel. Most of our work is now remote, but because we had invested in the training as well, we had a very robust training. I went out for site visits and trained colleagues, but each of the teams had access and opportunity to visit the other participating countries. So we had research visits, we had regular meetings on Zoom and in face-to-face, and we also provided leadership training for our early career researchers. And we had a very robust monitoring and evaluation program. So these are important pillars of successful research in international collaborations that we have learned a lot from. Just quickly about the context of each of the settings. So South Africa, we're working with GSH Hospital, part of University of Cape Town, and this is a hospital that has a very mature stewardship program led by Professor Mendelsohn. As I mentioned, they have many different interventions around stewardship. And in India, we're working with Amrita Hospital in Kerala, which again, through the leadership of Professor Sanjeev Singh, have been exemplary and have been leading the stewardship program in Amrita, not only in Amrita, but within the state. So they have, over the last 10 years, they have been working very closely at the federal state, at the both federal but also local state, to be able to work to not only have a stewardship program within the hospital, but also at state level ensure training for trainee doctors. Now they are training pharmacists in stewardship. And Amrita is an exemplary hospital by having engaged with pharmacists in stewardship. So it is a clinician-led, pharmacist-driven stewardship program. And the only way they were able to do this in a very hierarchical system was the championing of the leadership within the hospital who supported the pharmacists. We also worked very closely with the teams to build capacity, not only within our team, but also to share this capacity with people around the world. So we developed a massive open online course, which brought together all the learning we have done around applying social science research in antimicrobial stewardship. And this has been a really successful program, particularly, I think, over COVID as well. A lot of things have gone online. It's now in its 9th run. This slide needs to be updated. And we've had over 2,500 learners from around the world who have participated, who have engaged with us in dialogue on this course around what is happening in stewardship in their own settings. And this has been a really valuable exercise for us. And we've collated all the conversations we've had with learners on this course in a paper which is going to come out soon in JAC AMR. But it's really about learning from each other's experiences, and the sort of recurring themes that are coming through this dialogue is about limited roles of non-physician healthcare professionals around the world. We take it for granted that we work in places where pharmacists are involved in stewardship, where nurses have a role. In many parts of the world, this is still not the norm, and that's something that we should be striving to change and challenge by showing the examples where it does work and it works really well. There's a lot of report of lack of training of resources, even for those who are implementing antimicrobial stewardship themselves. Often people are going into this job without any formal training themselves. And one of the other recurring problems was that was expressed by our learners was the lack of understanding or engagement with public and patient populations around the threat of AMR and antibiotic use. So this is something that we want to build on, and we're now going to expand this MOOC by bringing in the learning and the findings from the studies that we have done in these different countries. But very quickly, I just wanted to highlight some of the work we have done and what it has taught us about antibiotic stewardship in different settings, focusing on the surgical pathway. And this was really fascinating for us because we using the ethnographic research, we mapped the surgical pathway in South Africa and India, and were able to describe the fact that, as I mentioned earlier, it's not just about surgical prophylaxis and surgical site infection management. So this is just an example from a patient. I think this was a patient who was in India, who had come in for removal of abdominal tissue, and she ended up staying in hospital for 42 days. And she had her operation on day 1, and she was given surgical prophylaxis. But then for the duration of her stay in hospital, she was given many different courses of broad-spectrum antibiotics, some of which didn't have appropriate microbiology and culture because of contamination or because of culture being taken at the wrong time. But regardless, she was still given the broad-spectrum antibiotics. And the other thing which was interesting, we tracked all the different people who are involved in the care of a patient in the surgical pathway. And for this particular patient, 84 healthcare professionals had a direct role in the infection management and antibiotic prescribing for this patient. So we have to really think broadly when we develop interventions to make sure we capture everybody who has a role in this conveyor belt system of antibiotic prescribing in the hospital, which is quite unique because for many other or most other interventions, it's very niche and very specific. The cardiologist comes and they do their own thing, and the intensive care team do their own thing. But it's the ubiquitous nature of infections means that everybody has a role and everybody gets involved and thinks that they're competent to be involved and do what it is they need to do. And that's something that we need to work with. We were also very lucky in South Africa that we had recruited a research nurse to our team, Candice Bonaconsa, who's now doing a PhD as a result of the work she did with us. And she had some experience previous to joining to us in visual mapping of communication in healthcare settings. So using sociograms, which is just sort of mapping the content and the direction of communication between different peoples in any setting. So we applied these sociograms to the ward rounds, surgical ward rounds, to try to understand who is controlling the narrative and the communication around infection management at the patient bedside for surgical patients. And we collected these sociograms and we quantified the episodes of communication. We differentiated this by whether it was antibiotic related, whether it was about removal of lines, about culture and sensitivity, about other conversations around the clinical needs of the patient. And more importantly, we were able to track who was initiating the conversation and who was enacting any decisions that were being made. And what we described is the majority of the communication on the patient ward round happens between the consultant and the registrar. And the nurses and the patient are this gray bar here. They have such little involvement in the patient, in the surgical ward round. And this is really important because particularly the nurses have key information about the patient's recovery, about the medication that the patient is on, about the wound, sort of health of the wound and the drainage. And despite all of this, they're not being pulled into the conversations to have a valuable role. And this goes back onto the hierarchies, on the cluttered space around the surgical ward round, and the time limitations that exist. And these are things that we should be looking to improve, and particularly for nurses to be more involved in decision making. And that's Candice is now looking at this, how we can bring nurses more into the decision making on the patient ward round. And this is something that I also observed in the research we did in the UK, that nurses had to actively be pulled into the discussion by the surgeons. And in fact, even where they position themselves on the ward round, you can immediately tell whether they're going to be an active participant or not. The nurses tend to stay on the periphery, on the outside, and it was always the surgeon and the registrar who were closest to the patient and who were sort of dominating the conversation. Alongside this, we also collected quantitative data. This is really difficult in different healthcare settings. In the UK, for my research, I had to laboriously collect data for each patient myself. And this is exactly what we're doing in South Africa and India. Again, this goes back to everything we say about the need for surveillance around antibiotic use and antibiotic stewardship. This is still a huge challenge in most settings because we do not have access to electronic prescribing records. We do not have access to mechanisms to collect patient-level prescribing data. For the little data that we were able to collect, or we are still collecting, so this is from 165 patients in the GI surgery. I've just pulled it out as an example. We looked at the quality of the prescribing according to the AWARE index, the Reserve, Watch and Access categorization. So in a hospital in India, most of the patients end up on the watch category antibiotics. And when they are prescribed antibiotics, the majority, 50%, have their antibiotic course unchanged until they are discharged or the antibiotic is stopped. And de-escalation occurs in 32%. So in 70, almost 70% of patients, there is no de-escalation or change therapy. And that's something, considering the majority are on watch category, is something that we need to focus on. But unless we are able to collect consistent data, we won't be able to do this. And this is a challenge in many different settings. I don't know how long I have, but I have a few more slides which I want to talk about. So we also looked at patient involvement, as I mentioned, because it was so there was so little patient involvement, and particularly in surgical patients, we think it's really important that patients do have a role particularly in preoperative preparation and postoperative recovery. Patient engagement is very important. So Aluchi, who is our pharmacist in South Africa, she's a postdoctoral research fellow, and she was very interested to pursue this. So she conducted a scoping review with us and colleagues to try and identify the existing evidence around patient involvement in surgical pathways. And she described this limited participation from the literature around involvement in IPC and in antimicrobial stewardship, particularly from lower middle income settings. There's very little data. And this is despite the many opportunities in the surgical pathway where the patient does have an active role. So that's something she's now pursuing as a fellowship, to be able to understand how patients can be more involved in not just decision making, but involved in self-care to prevent infections and to take antibiotics appropriately. And I know this is something that is of interest to colleagues in Australia as well, from some of the work I have read from the team there. Something else that came through, which again speaks to this issue of culture and how it influences decision making in different settings, was around the role of carers. In the hospital that we are in India, one of the regulations for being an inpatient or requirements is that the patient has to always be accompanied by a carer. And this is somebody who stays the night in the hospital if need be. There is a bed next to the patient bed, and they are always present to help with care of the patient. This, of course, has infection prevention and control implications. The carers are rarely engaged with in what it is they need to do whilst they're in hospital in terms of infection prevention and control practices, in terms of hand hygiene, if there is an outbreak. And they become the de facto carer for the patient in hospital as well, looking after them, helping them with wound care. And also, it is again a cultural difference. Often they are the advocates for the patient, and we observed on many occasions the teams would speak directly to the carer and not to the patient about critical decisions around the care of the patient, particularly if it was sensitive information around cancer diagnosis, end-of-life care, or about whether the patient can go home or not. Often these conversations were occurring between the carer and the healthcare team, and the patient was excluded, or the information that was filtered through to the patient wasn't the full information, depending on what the carer felt appropriate. And this is critical because this informal role that carers take on in different cultures and settings is often overlooked, particularly in infection prevention and control guidelines and policies internationally. And we have to work towards developing more culture-sensitive policies that take into consideration the role that carers have in patients in different cultures. And that's something that, again, I think is really important, particularly as we work across if you work in London, if you work in Sydney, in Melbourne, you are working across culturally diverse populations. And it's really important that we understand this so that the needs of different patient populations are addressed. I'm not going to talk about this. This was about some byline research we did around COVID vaccination, but it's kind of irrelevant to the talk today. I don't want to run out of time. I want to leave time for discussion. But I just wanted to sort of wrap up with a few slides on where this research has taken us, because one of the nice things about the work that I do, which I'm really fortunate, is I go around the world and I talk to people about what they're doing basically and how their work impacts their research and their clinical practice. And one of the recurring things that I've heard from colleagues, from patients, from researchers I've spoken with is about the role of socioeconomic inequities in antibiotic resistance, and not only from a care seeker perspective, but also a care provider perspective. And this is something that is really close to my heart and something that I think needs to be looked at. So we now have a researcher who is a PhD student who's going to be investigating the role of race, gender, and class, and how this determines how we seek care and how we provide care. And I saw this in terms of gender, gender hierarchies and disparities between surgical and medical teams, and the sort of the hierarchies between the pharmacy teams and IPC teams and medical teams. And there are all these power dynamics that are influencing how we dispense care to our patients. And one of the most important sort of critical examples that I always go back on was when I was on the ward rounds in Imperial for my PhD. There was an Afghan lady who was being sort of reviewed by an all-male surgical team, and I offered to translate for her because she doesn't speak English and I speak Farsi, which is very close to the language is almost similar, the language that is spoken in Afghanistan. And I translated for her, and the team made a decision, and they said, oh yes, she needs to have she needs to have her appendix taken out. Just send her for ultrasound and then take her to theatre. And after the surgical team had left, she asked me to go back, and she spoke to me and said, actually, I was really embarrassed to tell the team because they're all men. I have really unpleasant vaginal discharge. So she actually, and then when I spoke to her, she told me she had pelvic inflammatory disease, but she was too embarrassed to say it to the team, and she almost ended up having her appendix taken out. And this is an extreme example, but. And then I went back to the surgical team and I said, I think you just need a female gynecologist to come and see this patient. But, this is for me, these kind of examples, when you're between cultures and you observe care being given, it's really fascinating. And I think that's something that we don't look at enough in accommodating for the needs of different patient populations that we have, which is really important if we are to give everyone an equitable experience in terms of care. So these are some of the questions we're now going to address, or try to not address, that's a big word. We're going to try and understand how we can better meet the needs of different patient populations in terms of infection-related care. And just a couple of more slides which I want to talk about. One is about the inequities that we are still facing with, and I think this is something in our field to be able to change, is the inequity in LMIC versus HIC funding around antibiotic research, and the inequity in new drug research and development versus the kind of research that we do that tries to better understand how we can optimize existing drugs. Because unless we get this right, no matter how many antibiotics come into the market, we're going to fall at the same hurdles we have now. So I think it's really important that we try to advocate for more research that helps us understand how we can use antibiotics more appropriately, as well as research for new drugs and new drug development. And this includes looking at policy and strategies around antibiotic resistance and infection management, and the funding that is associated with it, but also understanding the contextual and cultural behavioral drivers for antibiotic use. And we worked with the Wellcome Trust, and Professor Thursky and others around the world contributed to this research, which was trying to develop a research strategy for antibiotic resistance for the next 10 years, taking into consideration all these factors that influence behaviors. And the other thing which I think as researchers we have to be more mindful about and more active in sort of adjusting the wrongs that currently exist in how we use the funding that we are given. This is from today from Professor Madhu Pai, who is in Canada, who is a global health professor, and he highlighted this inequity in funding, that even when we do receive funding for collaborative research, the majority of it still remains in high-income countries. And this is also translated in how we then engage with our colleagues in the global south in terms of authorship and representation of the work. And this is something that we've worked very diligently on the Aspires project to make sure that there is equity in this, but this is a challenge that we will keep facing unless we work with funders to make sure that there is equitable funding between different partnerships, particularly if they're across high and low and middle income countries. And this is really important because the challenges are greatest where the resources are least available. And that's something that we should be able to working towards addressing. And what it manifests itself into is this. So this is a publication by region. And as you can see, the global north dominates the authorship, and probably does that because of the imbalances in the funding. So that's something that I think as researchers, when we work together, we have to be really careful to address. And I'm going to stop talking there. I hope I have been able to demonstrate to you some of the research, the value of the research that we do in trying to understand how we can develop more contextually appropriate stewardship interventions, but also more equitable research partnerships. And for me, and I think for our team, it's never, the research is never the end. It's the partnerships we build, it's the relationships that we build that enable us to work together continuously and to learn from each other. And I think part of that is to be really open to reflexivity and reciprocity in research collaborations. I have a lot of people to thank. These are just some of them. Thank you very much.
Thanks, Esmita. That was, it's just so fascinating. And it actually is really interesting for most of us who are clinicians working in complex environments. In my mind, maybe it's antimicrobial stewardship and the word stewardship and this behavioural science which is driving what we do and is yet to be adopted in other areas of medicine and surgery. It's sort of like we're sort of forging this path of behavioural science to improve quality of care. And so that leads to this huge gap in knowledge and awareness of how to do it. And it's been stuck in that research, you know, percolating, as you say, percolating around in a research environment. But for us to get across the line, we actually need to have a clinical workforce that can do it. So it's a tricky question, but what is it that we need to do to upskill our pharmacists, doctors, nursing staff, and even our patients? You know, what's the next step? How do we get out of this echo chamber that we work in?
I think it's, so I came into this because when I qualified as a pharmacist, I didn't have a clue about antibiotics. And I actually went back to university and I did a degree in infectious diseases. So I think the first step is to look at how we train for the next generation. We have to be much more active in ensuring that the curriculum of our undergraduate healthcare worker trainees adequately address the issue of antibiotic resistance and using antibiotics appropriately, and equity, and you know, it links to socioeconomic inequities in health, as we've seen it manifested with COVID, because infection is a multi-pronged issue. It's linked to poverty, it's linked to lots of issues, and then to try and understand how you can correct some of those and the sort of the threat of antimicrobial resistance, it has to be done within a global health agenda and understanding. That's at the curriculum level for future. But for us right now in what we are doing, I think it's really important to shift away from this scaremongering antibiotic resistance is going to kill half the world by 2050 or whatever it is we like to say on any given day, but really engage with people in language and risks that they appreciate and understand. So, for example, when I speak to surgeons, I never talk about antibiotic resistance. I talk about patient outcomes, about length of stay in hospitals, about surgical outcomes that are relevant to that particular cohort. I think we have to change the way we are presenting ourselves, and there are lessons to be learned, for example, from the climate change movement, you know, how people have changed the dialogue and the narrative around what it is that they want to achieve, because there are lots of priorities in the clinical setting, and we're asking people to deprioritize other things and put us higher up the list. So it's always going to be a competing field. It's always going to be challenging, but we have to keep diplomatically having this dialogue with our colleagues and respecting where they're coming from as well. And I think that's something we can do better, is coming to sort of a middle ground as opposed to them and us, which I've seen to some extent from my colleagues. You know, we need to sort of reach a common ground of understanding, I think.
Now, lots of names have suddenly popped up on the screen, Arjun, so I'm assuming these are people who want to ask questions. So I'll start reading out. Fiona Goddison, who's one of our PhD fellows with NCAS. She's a nursing, I think you've met Fiona.
She spent time with us in Imperial, yes.
Yes, I know. So Fiona.
Hi there, Esmita. Thanks so much for that presentation. It's fantastic, of course. I'm really, I think certainly the point you make, Esmita, around culture, and I love that term of being between cultures. You know, you make that point about here, certainly in Australia, you know, we have many cultures working in healthcare, but also amongst the patient population. So I would suggest that, you know, from what I've seen in quality and safety, and even as being a carer in hospital, that's overlooked, you know, a lot, that notion of how culture matters in understanding infection prevention and control, and being empowered to have a role in that, you know, can be determined by where you come from and your previous experience. But I guess my other question is really around, you know, this interprofessional nature of infection prevention and control and AMS, and this idea of people understanding one another's roles. So, you know, talking about the MOOC and what you've learned about the different experiences from around the world, do people talk at all about how undertaking that sort of course or undertaking education and thinking about the role of different team members, how that's impacted their practice or their work, I suppose?
Thanks, Fiona. Yeah. Courtney, who has completed a PhD with NCAS, of course, and has really been leading a lot of the qualitative work around surgical prescribing. I can see Trish is on as well. So, Court, have you got a question?
Hello, Kaz. Sorry. Hold on, I did just write a question in the chat, but let me just read it out. Okay. Sorry, your ears must have been burning. I was writing it as you were talking about it. I guess my question then goes to that surgeon's role and responsibility as well. So we know that at the end of the day, the ultimate responsibility for surgical prophylaxis lays with our surgeons. But as we're aiming for a more multidisciplinary approach, and we need to balance having, you know, more cooks in the kitchen per se, how do we balance that? You know, we want our surgeons to be taking the lead, but at the same time, we're also trying to engage our anaesthetists, our pharmacists, our nurses. Like, I guess what is Esmita's thoughts on how to balance that, but still maintaining that the surgeon is involved and making those decisions as well?
Yeah, surgical prophylaxis is, you know, I think what the surgeon's insistence on or practice of prescribing more than is necessary comes from a place of, it's almost like a safety blanket and an insurance policy for them to not have a negative outcome for their patients, because for them, the reputation and the outcomes for their patients is so important. And that short-term gain is much more of a value to them than the long-term gain of, you know, if I don't prescribe one less dose of antibiotic, I may be helping towards reducing antibiotic resistance. So I think with the surgeons, the dialogue has to be around what the reassurance that, you know, the one dose surgical prophylaxis will not harm or have a negative impact on their outcomes. It's demonstrating that. And if you go, it's fascinating. I don't know if you've ever been, Courtney, to morbidity and mortality meetings that surgeons have to go to discuss their patients. You know, they're very thick-skinned and they rip each other apart. I remember I used to go to these meetings and they would talk about patients who've had sepsis, a patient who's died of sepsis, and they're trying to understand what went wrong. And they never talked about the infection or the antibiotic. They would talk about what mesh did you use? How did you close the wound? You know, that is what they care about, because they are surgeons. So either we have to completely de-skill them and take that responsibility from them and say, you do not prescribe surgical prophylaxis because that is not your job. But I don't think that's going to go down well at all. But it's about engaging with them in a language that they understand. So I always go back to, don't talk about antibiotic resistance to a surgeon. You've got to talk about the harm or the outcomes of giving one dose of surgical prophylaxis versus giving 2 or 3 or 4, and for them to convince them that giving one dose is as safe or safer than giving more than one. I don't know if that's answered your question, but I just think, you know, it's different. We are almost speaking different languages, and we need to find a common language to talk to each other.
Trish, did you want to make a comment?
Yeah, thanks, Esmita. Fabulous talk as always. I totally agree with what you're saying. We have to find the common ground. And I think one of the things we've observed is that common ground is best outcomes for patients. So wanting to make sure that the patient has the best possible outcome. And to the surgeons, the infection is a really devastating complication, and they want to do everything to stop that. So trying to provide some reassurance, like you're saying, that when you do this, it's not going to cause harm to the patient, it's not going to cause worse outcomes, is often the dialogue to begin with. But it also takes some time. And I guess the other thing I've observed with surgeons is they're very much about relationships and about trust. And if they don't know you, they won't take on your advice. They really want to be engaged with you, know that you understand them and are part of the team, rather than coming in as an outsider, just directing them to do things.
Yeah, and on that, Trish, it's really important. So I as a researcher went out with the teams, and I would be there 7:30 every morning. And they respected that, because that's when they start. Surgeons start their work at 7:30. And they said this to me: if you want to come and talk to us about issues for our patients, you've got to come at a time that is convenient for us. You can't rock up at 1 o'clock on the ward as an antibiotic stewardship person and tell us, when none of us are, we're all in theatre, and you want to have a conversation with us. So it's simple things that we do not take into consideration, is understanding the working dynamics of different teams and having to adapt to that and work with them. But the other thing, which is, it's a funny example, but I think it's illustrative of how we have become punitive in the way we try to sort of share our knowledge with people, is when I was on the ward rounds, there was one particular surgeon who would always wash his hands. And because I didn't tell people why I'm on the ward round, I wanted to sort of, Hawthorne effect and all. I just said, I'm here to observe clinical decision making. And he would wash his hands, and he would always make sure I catch his eye. He catches my eye when he's washing his hands. And then one day, one of his team asked me, why are you really here? And I would never lie if they openly asked me, and I would tell them. And I said, well, I'm here because I'm looking at antibiotic use. And then so this surgeon just turned around and said, oh, so you're not here for hand hygiene? And I said, no. And after that, he never washed his hands again. And that is, we have failed. That it's a right and wrong thing. It's like we're punishing them. He doesn't respect hand hygiene as integral to his practice for patient safety. That's wrong. That should be inherent. They should wash their hands because they don't want to kill their patients with germs, not because an IPC nurse is washing them. It's how do we make that switch? I don't have the answer.
There's a comment from Belinda, who is actually a nurse practitioner working with me at Peter Mac, and she does work with sepsis, allergy delabeling, stewardship, really pioneering a new role. Her comment is amazing. Thank you so much, Esmita. Empowering the nursing staff to work with the team and determining how to get to the medical team to listen to them. I think there is a translation piece. So just again, reinforcing that, nurses are the coordinators of care, and we need to be empowering them to be able to work in this space confidently.
Absolutely.
Yeah. Glenn. Sorry. Yeah. Sorry, Esmita. I'm just conscious of the time. We might finish up in a minute, but what we might do is, if you could just pop your questions into the chat, we'll we'll send to Esmita. She can email them back if you're happy with that, Esmita. Maybe the last question is Glenn, who works in a private hospital setting. So really another different dynamic again. Have you got a question, Glenn? He's a stewardship pharmacist. He's on mute.
Yes, I just turned you on, but there was a question from Courtney, and then I think Nanha as well.
Yes. Nanha? Can't see Nanha. She's dropped off. Is she? Court, last question for you. Or Sin, have you got a question? I can't tell if they've got questions, Arjun, because you popped them into the screen. Maybe Court, because I know you've got a question, then we'll finish up this morning.
So then I just, my question back to Esmita then is, like we've all talked about the importance of making the dialogue relatable to surgeons and focusing on patient outcomes and in optimizing patient care. Has she had much success with that? Has she been able to link the prescribing quality to outcomes, and how has she achieved that, or are there any works to achieve that across all the countries she's been doing all her research with?
So we're working in the UK. We have been able to now integrate a surgical pharmacist in the surgical cohort teams in specialties that we have, and we've been able to build that relationship so that there is, because that's what the other thing that was lacking is the investment that there was in medicine. We had a medical pharmacy team who looked after the needs of the medical patients and went on the ward rounds. We didn't have the same for surgery. So now that that investment's in place and that surgical, we have a liaison that directly works with the surgical teams, and I think that's worked really well. But in terms of more relevant to your question, in India, we've rolled out this sessions of sharing data on outcomes in terms of not just surgical site infection, but length of stay, outbreaks of the infections by surgical cohort, and doing root cause analysis of when there are unintended consequences, when there have been infections and SSIs, and sharing this with the surgeons, not just by giving them data, but we've had weekly meetings where we discuss, a bit like morbidity and mortality meetings, where we really discuss the patients, and it's led by the team in India with support from colleagues here who have experience of doing this kind of research and just training the teams in India. And that conversation and getting the surgeons to reflect on their own practices and behaviors has led to a lot of really useful insights in them to start thinking differently about their practices. The trouble is these things are very difficult to quantify, but we know that the relevance and the meaning and the value is there because of the way we're seeing the relationships change, and we're seeing greater engagement with the surgical teams that we are working with. But it's very difficult to capture that quantitatively, unfortunately. But I think that a lot of it is it's hard work. Building relationships really is what it's about, and that takes time and effort, and you've got to spend a lot of time with the teams to and this was through several iterations of co-developing these sessions with the surgeons, say what it is they want to discuss in these sessions and how we can come to a compromise that the discussions focus on infection-related care and how it can be improved rather than the mesh or the wound or specific things that they were interested in. But it's not been an easy process at all. I can't say there's a magic bullet that I can tell you what has worked. No, we're still learning.
We have several of our animal antimicrobial stewardship researchers online, and Rhea is one of them, and she made a comment. My limited research experience in the veterinary field totally echoes your point that it is more effective to talk about relatable and more immediate outcomes of inappropriate antimicrobial use than the big picture of global issue. I think all of us actually agree, and it's unfortunate in a way that antimicrobial stewardship, in my mind, has been tied so closely with AMR instead of patient safety and sepsis. And so my big push at the moment is to tie AMS and sepsis together, because that actually does work. That changes behaviours. So thanks, Rhea. I don't know if you want to follow up.
I didn't have anything additional to add, but just wanted to thank you for bringing up that point.
Up there, I think everyone has the fact that we've gone 10 minutes over time illustrates the urgency of the issue for people to understand this domain. And thank you so much, Esmita. I'm truly hoping that we can catch up in April next year in Lisbon. Of course, this has been recorded today, so we'll spread the word widely. Now, there's already been some interesting Twitter feeds this morning, which and I know you're an avid Twitter user, Esmita, so you'll be very happy to see that. So I'll finish up this morning, and thanks everyone for joining, and catch up with you all soon.
Thanks everyone. Bye.